I think we'll start. So yeah, so we can start. So we'll be talking about anemia today. Hopefully, God willing, tomorrow we'll try and then discuss sickle cell disease. Okay, that will be the other part of our anemia lecture. But today we'll be looking at anemia as a topic. We'll be looking at the different causes of anemia. We'll try and look at types as well. Okay, and then from there, we'll look at the management of each of the individual types that we'll be talking about. And hopefully tomorrow we'll touch on sickle cell disease because it's quite a big topic. So, I mean, I'm sure we've all consulted, and one of the usual diagnosis we tend to make is anemia. And the reason behind us making such a diagnosis is because we check the level of the person's blood, what we call the hemoglobin, the HB. Okay, and once we check the HB and the HB falls below a certain reference range, we go ahead and tell the patient that you are anemic, or what we usually say, umojaba form. So we need to give you something for your blood to go up. So according to classifications per the sex, we say that usually as an adult male, we expect that you'll be looking around 13. So if we check your HB and you're doing less than 13 for an adult male, then we can go ahead and say you are anemic. For an adult female, we'll say 12. So once you're doing less than 12, we can go ahead and say that you are anemic because your HB is less than 12 grams per deciliter. And for children, we would say 11 grams per deciliter. So once you're going below that reference range of 11 grams per DL, then we say you are anemic. Even though we have all these age ranges, I mean, HB ranges per the sex and then the age, usually once we say someone is anemic, in general, we want to say that the person's HB is less than 11, okay, in general. And once you want to classify anemia, we have a classification based on the severity. So you have mild, moderate, and then severe. And usually, if your HB, you have a patient who is doing about 10 to 11 thereabouts, then we say that the patient has mild anemia. If the patient is doing between 7 and 9, then we say the patient is doing moderate. And if the patient is doing HB less than 7, then we say you have severe anemia. So usually most of our patients, we tend to transfuse or we tend to give blood. We use an HB level of 7. Once you're doing HB level of less than 7, we say this is severe anemia. So we start thinking of a possible blood transfusion. Okay. However, you realize that when we talk about sickle cell disease, there's something we call steady state HB. So even though we know that HB less than 11 is anemia, when you're looking at a patient who has sickle cell, all of them have a certain steady state HB. So you can have a sickle cell patient who will tell you, oh, my HB is around 8 or my HB is around 7. Okay, if this person usually falls sick and comes to you, and then usually the HB is around 7, comes to you and you're checking and the HB is 6.9, you are not in so much of a hurry to say, oh, let me transfuse you because your HB is less than 7. Okay, because this patient's steady state HB is basically 7, and now you're recording about 6.5, 6.6. So we will try and manage you and see how it goes. But if you have a patient whose steady state HB is around 10, and the patient is now coming to you and you are doing HB of less than 7, then clearly you know that you can say, oh, this patient is having severe anemia, so I have to intervene. Okay, so for a sickle cell patient that you see, you can see a sickle cell patient whose HB is around 8, but the patient wouldn't really be showing any signs of anemia because the patient has survived for long on HB of about 8. Okay, that's the patient's steady state HB. So in this case, we are not in so much of a worry or a rush to correct that HB because that's the patient's steady state HB. Okay. So when we move on to the causes of anemia, there are so many different causes of anemia, so many. But the commonest cause, what we tend to have in our environment is nutritional deficiency. So most people who are anemic, It's basically because they lack certain minerals, certain vitamins in their diet. Usually, the three main minerals, vitamins you're talking about, the iron, folic acid, and vitamin B12. Okay, once you lack iron, folic acid, and vitamin B12, you would develop a low HP. And as we go on, we'll be parting them apart. So iron will cause iron deficiency anemia. So we'll take a look at iron deficiency anemia. Folic acid deficiency would also cause a certain type of anemia. Vitamin B12 deficiency will cause a certain type of anemia. But all this would basically amount to the main definition for anemia, a decrease in your HP. Once you have a decrease in your HP below the standard levels, which we've talked about, we go ahead and we say the patient is anemic. Apart from nutrition, another common cause of bleeding. Another common cause of bleeding is cause of anemia is bleeding. Okay, so basically what we have here is you have young female patients coming to us. You check their HB and you realize that their HB is low. This is because most of the time at the end of the month, some of them tend to bleed a lot, so we call menorrhagia. Okay, and sometimes some of them have some form of abnormality with their menstrual cycle, so they experience polymenorrhea and all those things. They can bleed about 2 to 3 different times in the same month. Okay, so in 1 month they have about 2 to 3 different cycles there. So patients like this will come to you with what? A low HP. Some people also have worm infestations and all that, hookworm and all those things. They tend to punch holes in your gut, and this will cause you to bleed, and then clearly you lose blood, you become anemic. Some people have peptic ulcer disease, and once you have an active peptic ulcer disease and it starts bleeding, your HP is going to drop. Okay, so we always have to be mindful if we have patients coming to us in the consulting room telling us that, oh, they have epigastric pain. One of the main reasons why we request for a full blood count is to look at the HP, because once the patient has an epigastric pain and you're thinking gastritis, always look at your HP, because you might just put your patient on omeprazole and Nugel and send a patient home, and a patient will collapse on his way home. Okay, I remember during my house job, ideally we weren't supposed to do locum. I found myself in some private hospital doing locum, and this young man came. He came with epigastric pain. I insisted. It was like, oh no, doc, I'm okay. I have ulcer. So usually when it comes, I just take, I'm late. I have to go to work. So you just request for medications for me and all that. So I requested for omeprazole. I gave the patient Nugel. The only thing that saved me was that I documented that patient asked to do labs, but patient has refused to do labs. That was the only thing that, covered me basically. So this patient went home after work and just collapsed. And then they rushed him to Rage, and he got to Rage. They checked his HB. His HB was around 3 point something. And then they were like, but he went to the hospital today. So who will see HB 3 point something and ask the patient to go home? So they traced back to the hospital, traced back to find the doctor who saw the patient and all that for sending a patient who has HB 3 point something back to work. But then when they checked the documents, it was there that patients insisted that he won't do labs. So patients went ahead to do an endoscopy, and this patient who had an ulcer was basically bleeding in the stomach, and at the same time had a very huge polyp in the stomach as well. Okay, so this patient had severe anemia secondary to bleeding peptic ulcer disease and then a polyp. If such things happen and you don't document, you are in trouble, because if he dies, medical legal issues, that's one. Okay, but let's say even if nobody finds out and this patient just goes and then dies, you would feel guilty. So whenever we are seeing patients and we are requesting for a full blood count, it shouldn't just be for formality's sake. I know that full blood count tells us almost everything. It gives you like a certain picture you want to have on your patient, but you should pay close attention to our full blood count depending on the cases that are coming to us. So you have a young lady coming to you with dizziness and all that, you go ahead and request for a full blood count. Don't just do it for the fun of it. You are doing it because you're thinking that probably this patient is bleeding a lot during her menses. So you just want to make sure her HB is okay. Okay, so bleeding conditions can lead to anemia. So we all have to be careful. People who have cancers and all that, they tend to bleed as well. If you have a leukemia where your white blood cell, they are basically abnormal. They are baby white blood cells, and you have excess of that in your bone marrow. So it has prevented your platelets and all that from developing. It has affected your how do you call it? Your red blood cell production itself. In this case, one, you are anemic. Two, your platelet levels are low. So the slightest cut, you tend to bleed a lot. So you lose lots of blood. Okay, so in this case, most of the time your patient will be anemic. So you always have to pay close attention to our patients, especially when we request for our full blood counts and we are looking at the HB. Another common cause is hemolysis. Okay, and hemolysis means that breakdown of red blood cells. So you can have a patient who comes to you as fine and all of a sudden starts having a febrile illness and then tells you that, oh, doc, now my urine looks like Coca-Cola. Okay, clearly this patient's red blood cells are breaking down. And as I said, we call it hemolysis, okay, or intravascular hemolysis. Common causes, you have a patient who has severe malaria, a patient who has sepsis, a patient who has sickle cell disease, G6PD deficiency, and goes ahead to take medication containing sulfur. Patients who have autoimmune diseases, some drugs in itself can cause you to hemolyze, okay, like Septrin and all that, if you are allergic to that. So all this is very, very essential that we look out for. And the classic aspect of this is that the patients who come to you with signs of anemia and tell you, symptoms of anemia, and then tell you that, oh, but doc, when I also pee, my urine is dark. And on your examination, the classic sign you find is your patient is pale and what's jaundiced at the same time. That should tell you that you are dealing with what? Hemolysis. Okay. Red blood cells are breaking down, releasing a lot of bilirubin. Your liver is unable to handle all of them. Hence, the bilirubin gets under your skin, under your sclera and all that, changes the color, and then it becomes yellow. Okay. Chronic conditions can also lead to anemia. Basically, chronic conditions would affect the metabolism of, your system. So if you have a kidney disease, a chronic kidney disease, we know kidney is essential and responsible for producing erythropoietin, and erythropoietin is a hormone you need in making RBC. So if your kidney fails, it means erythropoietin levels would also will drop, and hence you have a patient who is coming to you with anemia. Most patients who have CKD have anemia, and that's one of the things that kills them. Okay, I remember some time back, also private practice when I was with St. John's, they brought a young man, it's like 32 years, but he had developed a CKD, and that same day he had gone to Korle Bu for dialysis, and they discharged him. He went home. The mistake was that they failed to do a full blood count or check the HB. So he went in to do dialysis. I don't know who saw, but then when this man came to me, he was very pale. Like they just parked in front of the hospital, put him down. I started resuscitation and he died there. He didn't even enter the hospital. And the conjunctiva was white, like paper white. And this young man, 32 years, had chronic kidney disease and was anemic. Okay, so HB going low is something that we all have to be very, very cautious of, because that is what will kill your patients just there and then. We've lost a lot of people because of bleeding conditions, because of lack of production of erythropoietin, because of even nutritional iron deficiencies. People have died because of anemia. It's one of the leading causes of death in Africa and Ghana. So we always have to be careful. Tuberculosis, you are coughing, you are bringing out blood, hemoptysis, most likely you could develop some form of anemia. Hypothyroidism, your whole system is slow. Development of red blood cells are sometimes slower than expected. you have a patient who would come to you with a low HB. And then you can have certain autoimmune diseases like systemic lupus erythematosus, that's the SLE, and then pernicious anemia, which we'll be talking about. Pernicious anemia would usually affect vitamin B12. We'll be talking about that. Clinical features. So if someone has got anemia, how would you know the person has got anemia? So the person will come to you and there are usually some classic things they'll tell you. Oh, doc, my head aches and I feel dizzy. Sometimes they'll tell you my heart is beating very fast and as soon as I work, the slightest thing I do, I get tired. Worst case scenario, I can't even breathe. Once your patient tells you these things, headache, dizziness, palpitation, easy fatigability, these four things, clearly you should be able to tell that, okay, the patient's HB is likely low. Let's do a full blood count and assess the HB. Okay. Worst case scenario, they have breathlessness, so they are unable to breathe. Some of them will also come with the symptoms of the disease condition, which is leading to the anemia. So if you have a patient who has a colon CA or rectal CA, they will poop. And when they poop, there will be a lot of blood. It just comes like that, okay, mixed with the stool. The patients will come to you and tell you, doc, whenever I poop, there's blood in there. My HB is low. Okay, so that one, the low HB, you make a diagnosis of anemia, you make a diagnosis of anemia, but this diagnosis is not complete if you don't tell us what is causing the anemia. So usually anemia in itself, if you see a patient, you plug the patient and you write impression anemia, nobody will be happy with you. After your history and your examination, you should be able to predict the cause of the anemia. Sometimes you might be right, sometimes you might be wrong, but that's why your supportive investigations are there to rule out other things and to pick up other things. So if you say the patient has anemia, you are not done. So anemia secondary to, so maybe anemia secondary to chronic kidney disease, anemia secondary to colon CA, anemia secondary to bleeding peptic ulcer disease, anemia secondary to intravascular hemolysis. Okay. And it's also not enough to just say anemia. You have to try and qualify the anemia. So you have to tell us severe anemia secondary to intravascular hemolysis in a patient with severe malaria. So once you say that, we know that you have a complete grip, you know what is causing the anemia, and you know the type of anemia we are even dealing with in the first place. Okay, so look out for the classic symptoms the patient will tell you: headache, dizziness, palpitation, easy fatigability, and the additional symptoms they would also give you, which would point you in the direction of the cause of the anemia. Now, it's up to you to examine the patient. So the usual thing we do is to look out for pallor. How do we do that? You're going to look at the conjunctiva, you just pull it down a bit and then try and check the coloration over there. Sometimes we look at the patient's palm, but you always have to compare it to something. So you look at the patient's palm, you compare it to your palm, and then you see if you're pregnant and the patient is pregnant based on your patient is anemic based on your findings. And even if the patient is anemic, we try and find out the cause of the anemia, which could be pregnancy, it could be other things. Okay. So just be sure that yourself as a clinician, you are not anemic, because if you as a clinician, I mean, your HB is low and your palm is a little bit white and you're trying to compare, you might not be able to make like a good comparison. So examination in this way is usually subjective, it's not objective, and that's why you still need to check your HB after you've tried to elicit for pallor. So the other thing too is you try and you look out for jaundice to see if patient is hemolyzing or something. You try to look at the heart rate of the patient as well. Okay. Basically, what happens in anemia is that once your HB drops, your body tries to compensate, because when your HB drops, it's like oxygen delivery to your tissues have dropped. The HB is the hemoglobin is what binds to your oxygen to form oxyhemoglobin, and then this is delivered to your tissues and all that. So with low HB, comes low oxygen delivery to tissues. Okay, and we know that whenever the system or the body feels that oxygen delivery is impaired, it goes into a compensatory mode to try and then make up for it. So it tries to increase the cardiac output. And in increasing cardiac output, remember we said cardiac output is what? Heart rate times stroke volume. So things such as your heart rate would go up. Okay, and then the whole system is sort of hyper exaggerated in quotes. So you can sometimes feel a murmur. Okay, a murmur will usually happen when the heart is trying to forcefully push blood and all that. So it gives off some sound, so you can hear a murmur. And in extreme conditions, the heart can actually fail because it tries to overcompensate for the low oxygen delivery. So the heart basically tries to overwork itself, and then in the end, you have some other features too that will tell you the type of anemia you are dealing with. Okay, there's something called Koilonychia angular stomatitis, which you usually pick up when you are dealing with iron deficiency anemia. We'll be talking about that as a subtopic, so we'll see Koilonychia and angular stomatitis again. General investigations for anemia, we'll do a full blood count. Okay, it's not enough to just do HB. Sometimes I know patients who say they don't have money, so we say, let's do HB. Let's do HB. No, it's not enough to just do HB, because when you do HB, you miss a lot of the other parameters. And as we go on with this lecture, you realize that the other parameters are also very, very, very helpful. So a full blood count has a looking at the red blood cell compartment, you have your HB, you have your reticulocytes, which are your baby red blood cells. Okay, you have your mean corpuscular volume or mean cell volume, which we call the MCH, MCV. We have the mean cell hemoglobin. Okay, so you have all of that, MCH, MCV, and all that there. And those parameters are very, very essential because it tells us the type of anemia we are dealing with. It doesn't only state that, oh, the patient's HB is low, so the patient is anemic. But then when the HB is low, and then we look at your MCV, okay, which we'll be talking about that in a little bit more of a detail very soon, or your MCH, which we'll be talking about that as well. And then we realize that it is abnormal. That can point us to the direction of anemia you have. It can tell us if your anemia is secondary to iron deficiency, or your anemia is secondary to what? Folic acid deficiency, your anemia is secondary to vitamin B12 deficiency. Okay, so it's very, very, very essential that when we want to request to check HB, we don't just say, go and do HB or check HB. A full blood count is very, very vital. Okay, your reticulocyte count, ideally, if you have a patient who has anemia, ideally, once the HB is dropping, your body compensates and your body realizes that I don't have enough red blood cells. So what do? Let me make a lot of red blood cells. So people who are usually anemic have a high number of reticulocyte counts. And this is because the body tries to compensate to make a lot of cells. So they have an increased reticulocyte count. Okay. The exception to this is if the cause of the patient's anemia is secondary to failure of the bone marrow. If the whole bone marrow has failed and the patient is anemic, this bone marrow is responsible for making your reticulocytes. So if your anemia is secondary to bone marrow failure, clearly we are not going to get reticulocytes as well because the marrow has failed. But if the marrow is working, once the marrow is working, a patient who has low HB would try to compensate. The body will make a lot of reticulocytes. Okay. Then you can do a blood film comment. The blood film comment will tell us how your red blood cells are looking. Are your red blood cells smaller than the usual? Are your red blood cells bigger than the usual? Are your red blood cells more red, or someone would say they faded? Have your red blood cells faded as compared to the normal? Your blood film comment will tell us all that. Then your blood film comment can tell us if your red blood cells are looking like a crescent shape, which can point to sickle cell. Your red blood cells are looking like a teardrop. Okay, it will tell us all of those things. Okay, the additional tests that we can do a sickling test, HB electrophoresis, because we know that sickle cell anemia can definitely cause your HB to drop. So once a patient is coming to you for the first time, you don't know what you are dealing with, and a patient's HB is low, especially in children, always do a sickling test and then HB electrophoresis. Okay. We'll also need to do a BF4-MPs. Usually full blood counts will go with BF4-MPs because we know that severe malaria, one of the complications of severe malaria is intravascular hemolysis, which will lead to anemia. So always have to look out for that as well. And then BE and creatinine, because we were saying that chronic kidney disease, erythropoietin production will drop, HB will go down. And one of the ways of picking up your chronic kidney disease is that when you do your BE and creatinine levels will be very elevated, urea levels will be very elevated. That tells you that the patient has a kidney disease. Okay. Still on investigations, there are other things that we do. We do iron studies as well, especially if you think your patient has iron deficiency anemia. We do iron studies. So once we get to iron deficiency anemia, we'll be touching on iron studies as well. Then you can check the blood level for vitamin B12 level, for folic acid level, and all that if you think that that is what is causing the deficiency, especially if your blood film comment is pointing towards a picture of a folic acid deficiency or vitamin B12 deficiency. You can check for the quantity of vitamin B12 or folic acid in the blood, and then that would tell you what you're dealing with. There's also what we call a Coombs test. And this Coombs test is essential for picking up autoimmune conditions. So any hemolysis, which is secondary to an autoimmune condition, when you do a Coombs test, you can pick that up, the antigen antibody complex up. Okay. You can check the stool for occult blood. Some patients will come to you, you take your history and will tell you, oh no, when I poop, I don't see blood in it. But then if you do a stool for occult blood, that can tell us occult means hidden. So you can do a stool exam for hidden blood. Okay, it's a special test that we do. And then once we do, we can tell that we can't see the blood with our eyes, but through our stool for occult blood test, there's actually blood in the stool. So whatever is causing the low HB is along the GIT. You can also check the stool for hookworm over and all that. That will tell you are dealing with a worm infestation. Okay. A urine array is also essential because if you do a urine array and you see red blood cells in it, clearly you know that you have hematuria, and hematuria can lead to anemia. Patients who, especially those who come with bleeding along the GI lines. So if a patient comes to you and is pooping, there's blood in it, or is pooping and then the blood is stuck, or vomits, and then whenever he vomits, blood is coming out, you need to do an endoscopy for this patient to look out for the lesion. Okay, so you can see that the other investigations, not only to say the patient is anemic or not, you've made your diagnosis of anemia because your HB is low. That's all you need to make your diagnosis out where the cause is coming from. And that is where these additional labs come in. Okay, so the link will be dropping in the next 5 minutes. So at this point, I'm going to pause. I'll take questions before we move on to our next subtopic, iron deficiency anemia. So any questions, please?
Sir, good evening.
Yes, sir. Good evening.
Please, can you throw more light on the Coombs test and the reticulocyte count?
All right, okay. So thank you very much. The Coombs test is more of something that we do to determine immunological factors, antigen antibody test. We have what we call a direct Coombs test, and then we have what we call an indirect Coombs test. Okay, so what is going to happen is usually if you have a patient who you think has some form of hemolytic anemia secondary to an autoimmune condition, we can take the patient's blood sample and then using the Coombs reagents, you try and then you test for it. What you are aiming to do is you want to see whether you can pick up an antigen antibody complex. Okay, so it's more of an antigen antibody examination. So you want to try and pick up a complex. Usually when we say direct Coombs test, it means that you are looking for the antigen antibody complex on the red blood cell itself. Okay, so it's directly on the red blood cell, but indirect means that it's not on the red blood cell, it's just in the circulation. So an indirect Coombs test would also pick an antigen antibody. You have this an antigen and antibody complex coming together, and then once you pick that up in circulation, which is directly not bound to a red blood cell, then you say that one is an indirect Coombs test. So it's more of reagents. We use reagents and then the patient's blood, and then we try to look out for immune complexes. That's all. That's for a Coombs test. So most conditions that results in hemolysis secondary to autoimmunity, Coombs test is what we use. So let's say classic condition, you have a child who is rhesus negative, and then a mother who is a child who is, let's say, coming from a rhesus positive father. So the child picks up whatever the father is coming with. Then so now the child has rhesus positive, but then the mother is rhesus negative. Okay. Rhesus negative means that the mother doesn't have rhesus antigen on her red blood cell, but this child has rhesus antigen on his red blood cell. Once you have this, what happens is that the mother will identify the child's rhesus antigen as a foreign body and start producing a lot of antibodies against that. These antibodies will go and bind to the child's rhesus antigen and form a complex. And once it forms a complex, the complex will destroy the red blood cells, which will lead to fetal anemia. So if you want to test for this, you do a Coombs test. You take the blood and then you try and then you test. So what you do is we can take the mother's blood and then do a Coombs test. And all we want to see is if the mother's blood has been exposed to rhesus antigen, and hence there's antigen antibody complex in the mother's blood. Are you okay with that?
Yes, sir.
Yes, the reticulocyte count, I said that reticulocytes are baby red blood cells, which usually your body produces. So for a red blood cell to become a red blood cell, it has to go through stages, reticulocyte, and then later develop into a mature red blood cell. Okay, what happens is that when your HB is dropping, usually your body detects that my HB is falling, so let me make more red blood cell. So as a compensation, in making the more red blood cell, the red blood cell will have to go through stages first, right? So at that point where the patient is anemic, the reason why the patient is anemic is that the patient doesn't have enough red blood cells. And red blood cells, when you are making them, it takes a while. So once you make the red blood cell, at that point where the patient is anemic, the red blood cell the body is trying to make are still baby red blood cells, which we call reticulocytes. And that's why the patient is even anemic, because if this reticulocytes were matured red blood cell, the patients wouldn't even be anemic. But because they are baby red blood cell, the patient is still anemic. So when you check, you find a lot of the reticulocytes. Your body is trying to compensate by making a lot of red blood cells, but the red blood cell would have to be reticulocytes first before they become red blood cells. Okay.
Okay. Sir.
Yes, please.
Sir, so if I can get you clearly with the Coombs test.
Yes.
Hello?
Yes, Evans. Yeah. Yes, Evans, I'm here.
Yeah, with the Coombs test. So does it mean the direct is with the children, and the indirect with the fetus, or like the neonate, and the indirect is with the mothers?
Okay, so yes, so usually what we tend to do for the mothers is more of an indirect Coombs test. Okay, for the example you gave, the example I just talked about concerning rhesus isoimmunization, usually we tend to do the indirect for the mothers, but Coombs test is not only used for rhesus isoimmunization. There are other conditions that will lead to hemolysis that you need to do a Coombs test for the patient, where it doesn't involve a baby. You have a mother who has an autoimmune condition with red blood cell being destroyed. Okay, so you have hemolytic condition secondary to an autoimmune disease. So the autoimmune disease is breaking down the red blood cells. Once you have something of this sort, definitely, if you decide to do a Coombs test, you don't have a baby involved here, so you can't say that the direct is for the baby. You can actually do a direct Coombs test for the mother as well. But then, in the cases of rhesus isoimmunization, we usually tend to do the indirect just to detect